So I will restrict my talk over the next 15-20 minutes to give you an idea as to what this new term that you're looking at, precision medicine, is all about, and its relevance or connection to diabetes. Alright, so that's the overview. So I'm going to quickly go through 3 cases. Let's see if we can find something common between all of them, and that will set the base for me to introduce the concept. So scenario 1, Raju and Shamu, I made up the names, they are brothers. Both of their parents had diabetes. Okay, so they decided they must do something to make sure that they don't get diabetes. Okay, so they both, let's assume, start at the same BMI, eat food from the same kitchen, work in the same office where stress levels are all taken care. Both of them decide to do the same amount of physical activity and eat healthier. But 8 years down the road, Raju is found to have diabetes and Shamu does not. Right? We've had scenarios like this, right? Fine. Situation number 2. Now, 2 30-year-old men found to have diabetes a year ago. Both of them are currently on 2 grams of metformin per day. Both of them claim to be diligent with their physical activity and also intake of medication and eating habits. Now, patient A has a HbA1c of 9.2% and patient B has a HbA1c of 5.6%. Have you seen such patients? Yes. Case 3, both of them are 50 years of age with history of diabetes for about 5 years, hypertension, on statins, non-smokers. Both of them have microalbuminuria. 5 years down the road, patient A continues to have normal EGFR with microalbuminuria, whereas patient B has progressed to have macroalbuminuria and second stage 3. That is also a very common scenario. So we've been through 3 cases where similar, even if you adjust for many of the confounding factors, there are still some things which happen, let's say in the onset of diabetes, in the natural history or the course of diabetes, and also in the incidence of complications in diabetes, which you and I cannot really quite understand or fathom. Okay? So that essentially brings me to the point where we all kind of know it and agree that although we all classify them as type 2 diabetes, it is a very, very heterogeneous condition. It is very heterogeneous, it presents differently, it progresses differently. So, presuming that we can treat them all, where you have one set template and say, this is what I do first visit, this is what I do second visit, this is what I do third visit, might not work so well. You and I are very much appreciative of this fact. So that brings me to the introduction of the concept of precision medicine or personalized medicine. So if you look at this picture here, where we think that one drug, one protocol, one flow chart for all patients, versus a personalized medicine, it's a self-explanatory term. You're accounting for the fact that each individual patient is different, they come in all sizes, you accommodate for those differences, and you provide a treatment which will be tailored more to that patient's needs and requirements, will also be watchful of that person's adverse reaction to the drug, and thereby probably provide a better form of treatment. That is the essential idea behind personalized medicine. So I began to wonder if Hippocrates was actually talking about personalized medicine when many, many years ago he said it's far more important to know what patient has the disease than what disease the patient has. I'm sure he was not, but yeah, it rings a bell. Okay. So quickly going through the definition, pretty much what I've just told you about is to tailor treatment to individual characteristics, the ability to classify a group of individuals into subpopulations who might differ in their susceptibility and also their response to a specific treatment, thereby hoping that you can give medications to a patient so that he will reap only the benefit with a very low incidence of adverse effects. Personalized medicine is what I'm talking about, but my topic is precision medicine. Both of them pretty much come to mean the same. Precision medicine is the preferred terminology to be used when we're talking about the idea that I'm referring to. And what might be, can you think of any other specialty of medicine where precision medicine or personalized medicine has been taking huge leaps and strides which has kind of changed the landscape of treatment?
Hematology.
Oncology. Okay, yes, cardiovascular therapy, aspirin therapy, but oncology is where it is actually translated into clinical practice, right? Now, you know, immediately after a breast surgery which is done for breast cancer, that sample is sent for typing to see which estrogen receptor is present or not, and that in turn will change the way they receive follow-up care and treatment. Okay, so that is in the essence what we plan to do for for patients with diabetes when we talk about precision medicine in patients with diabetes. Okay, so let's start with what makes us all different. Okay, apart from the fact that we might like different things, what makes us all essentially different is probably down to the thread of it all, our genome. So that's a good place to start, right? So there are two major advances which happened over maybe the last 2 decades, which kind of fueled our interest in precision medicine. One was the fact that we developed the ability to map the entire genome of the human body, and then that data has been out for a few years now. And then another thing which happened in the field of technology was our ability to process massive amounts of data, distill it, and get information which is actually relevant and useful to us. Otherwise, what's the point of seeing pages and pages of GATC, right? Both of these developed, and that in turn led to the fact where precision medicine worked out for oncology. Precision medicine in diabetes is garnering lots and lots of interest. So much so that in the last IDEC, there was a meeting held specifically to address this, where they looked at new clinical strategies in the management of diabetes. Up to 6 articles from that meeting were published in Diabetes Care, which followed that year in July 2016. So if you want a quick editorial to read to get an idea, probably July 2016 editorial is the place to start with. Okay? So where can we apply this clinical genetic information in clinical life, right? You could potentially use it to predict who's going to get diabetes, right? You could potentially use it to see how they are going to differ in terms of developing complications. You could also probably use it to change behavior based on, let's say, their risk for complications or their risk for disease. And you could also probably find drugs which are specific for your patient. That's the scope of how precision medicine pans out in diabetes. So let's start with risk prediction. Okay, we all know that diabetes is a disease which has a very strong genetic component. If both of your parents have diabetes, your lifetime risk is around 7%, right? So if you look at genetic data, you must find something conclusive, right? That was the thought. And there are many genes which have sounded promising all along for many years. Some single genes, some associations with genome-wide association studies. And overall, quite a few genes have been documented or found to be in evidence. But I want to draw your attention to this column here, which is telling you the odds ratio for each particular gene defect. Okay? One of the most prominent one of them all is this TCF7L2 gene, and notice the odds ratio is 1.37, which means it does confer a 37% increased risk, but that is not quite enough to explain the increased incidence of diabetes per se. And now this is a study which looked at all the various loci, and look at this. Collectively, all the genes could explain only 10% of type 2 diabetes heritability. Okay, so could it be that there was something beyond genes which was affecting our risk for diabetes? Probably. This is what is referred to as epigenetics. I'm going to take you through it. So we know that DNA leads to RNA by transcription. RNA gets translated to protein, which in turn will lead to a particular effect or a non-effect of it. Okay, but now we've come to understand that this process of DNA getting transcribed to RNA is not a simple process. There could be other factors which could be affecting whether the gene is being transcribed or not. So you might have a good gene, but it is not being expressed. You might have a bad gene. Somebody is not stopping it from being expressed. And this is what is called as epigenetic changes. In the plenary session, we heard Dr. Nihal Thomas talk about the Barker's hypothesis, where low birth weight children went on to have worse metabolic profiles. This epigenetic change is supposed to be one of the factors which contributes to that Barker's hypothesis. So the exposure of the intrauterine factors when the baby was in the womb of the mother predicts how the life for that particular baby is going to be 20 years down the road, irrespective of what the genetic makeup is. Which means that you could have the genes, but something along the way changed, which made the good genes also become bad. Okay, just to put it simply. So it's not just genes, right? So then, would it be better if we looked at RNA, right? If you looked at RNA, so we could bypass the epigenetic changes, right? That aspect of precision medicine is called as transcriptomics. It's very simple. Transcription leads to RNA, so you can get a whole bunch of RNA and assay it from each cell. Will you learn anything more? Could you take it a step further? There's something called as proteomics. Proteomics is where you look at proteins which are present in a single cell and see what's different between a patient with diabetes and a patient without diabetes. And there's something beyond that. They said, why only proteins? There could be other molecules which is affecting metabolism. It could be amino acid, it could be fatty acid, it could be anything else. Why only proteins? And that study is called as metabolomics, where you look at all the molecules which could be affecting metabolism. Now, just focus on metabolomics, because metabolomics seems to be the most active area of research in precision medicine when it comes to diabetes. I'm quickly going to take you through just one or two of them. So this is a paper which is published in 2016, which looked at association of the amount of amino acids, especially branch chain amino acids and aromatic amino acids which was present in the cell, and whether it was able to tell us your risk of developing diabetes and pre-diabetes. And it was shown that if you had a greater percentage of branch chain amino acids and aromatic amino acids, you had an increased risk of diabetes. I do not have the time to try and explain the connection, but I'm just going to go through. And this is another propionic acid. Okay, they have found that when this propionic acid level increases, this is the beta cell. The beta cell preferentially takes up fatty acids for oxidation and is no more responsive to glucose metabolism, which essentially means the glucose sensor takes a back seat, and if the glucose sensor in your beta cell is not working, your insulin secretion is going to be affected. So they looked at this propionic acid levels. This is an animal model study. I forget if it's an rat or mouse, but they showed that when the levels of this CMPF levels increased, that was the tipping point which turned the normal rats into pre-diabetic or diabetic rats. Okay, so metabolomics is the hot area. So another area where you could be looking at genetic risk counseling is, let's say we look at your gene and we find out all that you are prone to. Okay, and then if I tell you that this is what you are at risk for, will you change your behavior? That is an interesting area to study too, right? So that is what this randomized trial did. It took a whole bunch of people. It did genetic testing for half of them, did not do genetic testing for half of them. They brought the people who got the genetic testing in for a counseling session. They said, this is what you're prone for, this is what you should be doing, and this is what we will assess at the end of a few months. And then at the end of a few months, they looked at patient self-reported attitude, what they were doing about their weight, what they were doing about their eating. And what they found was, although they knew what they were prone to, there was no meaningful change in behavior to recommend genetic risk screening to tell you that you have diabetes, right? You and I could do a BMI, a waist circumference, right? Presence of acanthosis, presence of hypertension, and probably predict much better. Okay, so I'm going to pause at this moment. We all know that type 2 diabetes is a strong genetic predisposition. We've now come to understand that genetic risk scoring does not score too much over the clinical risk scoring that you and I do every day in clinical practice. Metabolomics is where you assess all the metabolites which is present in an organism to see if there could be any connection for metabolic dysmetabolism, and this is an upcoming area in the scene of prediction of diabetes. But behavioral changes have not shown to be conclusively positive, but of course there is data for 1 or 2 studies only, we're waiting for more. Going on to the more interesting aspect of pharmacogenomics, self-explanatory, it's the application of genetic technology that can be tailored to those patients who are most likely to benefit without having the side effects. I'm going to just go through metformin, about 15 papers on metformin and pharmacogenomics in the last 2 years. So just I'm going to go through metformin. If you go back to your pharmacology textbook in school, pharmacokinetics or even action, mechanism of action is very vague. Even now it is very vague. So we're learning lots and lots about a drug which we've been using for a long time. So this is the gut from where metformin is absorbed. There are 2 important transporter proteins. This transporter protein first is called OCT. It stands for organic cation transporter, and we need this transporter for metformin to be absorbed from the lumen into the cell, and then from there into the blood as well. Metformin's primary focus of action is at the level of the liver, where it needs OCT again to enter the hepatocyte, and then it is being chucked out of the liver, it is being excreted into the bile through a second transporter protein, which is the MATE, which is the multi-drug and toxin extrusion transporter. There are many isoforms for both of these, but suffice it to know that OCT works for entrance and MATE works for exit. These same transporters are there even in the kidney. Kidney is the primary route of excretion of metformin, OCT for entry and MATE for extrusion. Okay. Now, identifying these 2 transporter molecules led to a flurry of activity in in trying to understand why some patients do so well with metformin, why some patients cannot tolerate metformin at all. Okay, so it's a busy, crazy slide, but you should not be focusing on the detail. Just understand that many of these individual variations have been attributed to two of these transporters, the OCT and the MATE1. Okay, I'm not going into the details. Similarly, when it comes to pharmacogenomics of sulfonylureas and glenites, many potential. Some which you can expect. The top two genes are the genes which express the KIR6.2, which forms the ATP sensitive potassium channel, and the second gene there codes for the sulfonamide receptor 1, which is the receptor on the beta cell. So it is understandable that these variations are the ones which explain patient response to sulfonylureas and glenites. This is something we spoke about. Some patients, Dr. Vijay Panikar told us that some patients on GLP-1 analogs lose lots of kgs and some patients gain kgs. So this is, they have found some changes in those GLP-1 receptors, polymorphisms also, which can explain the differences. Similarly for SGLT2. So there are many drugs and there are many potential areas which have been identified to be different. Okay, but it could be so. But how well does it translate into your and my practice, right? Does that mean the next patient who's having metformin intolerance or failure, you send them over for, I don't know, to a genetic lab for testing? So this is a systematic review which was done in 2014, which took a look at all the published papers till then in 2014 to see if pharmacogenetics was something that was relevant in type 2 diabetes. Okay, there were totally 34 studies, but there was no prospective randomized control trial. Up to 1/3 of them did not have a control group, and up to 1/3 of them did not report on loss to follow-up. And pharmacogenetics was just a sub-study in a study which was looking at something else. So it was not a pre-specified analysis. The conclusion of this systematic review was that for now, there is no strong evidence to suggest that you must be routinely doing pharmacogenomics. But if you get enough data from properly designed randomized control trials, but till then we just have to wait. But it's important to appreciate that, yes, probably it is so. When your patient tells me that he's truly not able to tolerate metformin, it could be a pharmacogenetic variant. Okay? Susceptibility to complications. We all know that not all patients with diabetes develop nephropathy. Not all patients with diabetes develop retinopathy. Many isoforms or polymorphisms have been noted. For example, aldose reductase genes polymorphisms are attributed for the differences in diabetic retinopathy development, ACE polymorphisms for development of nephropathy. No clinical studies could be found in this regard. Do you anticipate any potential barriers? Of course, yes. The potential barriers could be technical and also clinical. Technical in the fact that there is so much of money to be invested in a genetic lab. So just to analyze the human genome product, crores and crores of dollars were spent in. It is resource intensive, it is labor intensive, but you also need technology to process that data and give you information. But in infancy, everything seems like that. So the first computer which was built filled the whole room up, or so they say. But now you and I cannot imagine a life without computers. So we'll have to wait and watch. And for any new technology or a genetic test to be out in clinical practice, just like how it is for drugs, there are many stages or phases it has to progress to. And currently, precision medicine in diabetes is somewhere here in the preclinical phase. How quickly it transitions is something that we have to wait and watch. But like Sir said, when he said 20 years down the road, we might have a cure for diabetes. Similarly, there are a set of doctors who believe that we might have a scenario which is different from the current scenario. Currently, this is what we follow. It might change to a precision way in the future, where you will have the black patient's genetic risk scoring, maybe also data from metabolomics to tell you his predisposition percentage for diabetes, and instead of just starting metformin, you will have data from a pharmacogenomic lab to tell you which drug to choose from and which not to, and also you have a list of complications that he or she is prone to. So that's what it might look in the future, where you will have a health record system or an assistant which will aid in decision making while you treat patients with diabetes, with all this data being generated even before they reach your clinic. So is there a role for precision medicine in diabetes? Of course. But has it reached its full-blown utility? Not yet. We've spoken about how metabolics might play a role in prediction of diabetes, how pharmacogenomics affects different patients' response to medications, how its relevance in complications of diabetes, and the potential barriers. So we might see a day where we look at the genome and say, this is the drug for you. But while that future is somewhere in the future, not so distant future, today is a gift and it's still present right here. So if it were not for the great variability amongst individuals, medicine might as well be a science and treatment might as well be given by robots and not an art. So thank you.
Thank you, Chitra. Very complex topic, but you very quite central. One or two questions, if time is there.
Yes, sir. Right. For aspirin resistance, yes.
The cardiologists are very fond of using this kind of the pharmacogenomic study to identify where the patient gets an adverse effect. Like if we give any therapy to the patient, there are four outcomes. One will respond very well. Second, he will respond partially. Third, he will not respond at all. And fourth, he will have adverse event. I think whether to find a responder versus the adverse event, I think the pharmacogenomics is a good way of doing it. In the Western countries, they charge $1,000 to do studies about some 26 drugs or so study, and among that the metformin goes one to 10, where they find out whether you have a OCT mutation or a main mutation to find out whether the drug is absorbed, because the metformin drug is absorbed as it is and excreted as it is, and no biotransformation in metformin. So I think probably a lot of good future and you did extremely good job and very nice, crisp presentation.
Thank you.
I just appreciate it.
Thank you, sir.
Thank you, madam.
Last question.
Yeah, this is a comment basically. I go back to those days when you were in IDEC.
Yes.
Student over there.
Yes.
We used to go to the CNA. Yesterday, Dr. Selvan came. I don't know if you have met him or not. And in this conference, we are sensitized about the genomics. This is the second time. Yesterday, Dr. Selvan also touched it, and today also. You did a very wonderful job. Thank you, madam.
Thank you for the kind comment.
Last comment, Chitra. How do you see future regarding the diabetes as far as the genomics are concerned? Because it may not be very cost effective.
Yes, sir, definitely yes. Forget cost effectiveness, even realizing the whole dream itself is still, I feel, in the pipeline. So hopefully we will see it in our lifetime, so let's wait and watch. But lots of activity, at least in the publication world from the Western world. So.
Thank you, Chitra, for a very nice talk.